right. So have any of you, before I start, have any of you worked with prostate cancer patients before? Okay, so hopefully some of the information that you get tonight, if you do come across a cancer patient, will help you in the future. So I thought I'd do something a little bit different from what we've been doing kind of regularly on the Coach's Corner, and that's talk about exercise and prostate cancer. So a little bit about me. Currently the exercise physiologist at Absolute Health Performance. I was with Boxhill Hawks in the VFL last year. Prior to that, I was based in Sydney. And I worked for a physio company, P360. I was the EP and S&C at One Body Health and Fitness, which was a triathlon coaching company, and I did some performance analysis contractor work through InSwitz. So things I'll be talking about today. So I'll go through things about prostate cancer. So what is the prostate, some overall stats, diagnosis, common treatments, side effects, exercise considerations that hopefully I will instill onto you guys about things around screening, prescription and monitoring. And then I'll go, and I'll kind of touch on some of the research present. So the prostate, so the prostate gland is responsible for the fluid necessary for ejaculation. It is situated within the pelvis, just underneath the bladder. The nerves that stimulate an erection are interwoven within the tissues of the prostate. So this is why erectile dysfunction is a common side effect with prostate cancer treatments. And some other conditions that the prostate can go through is prostatitis, which is inflammation of the prostate, and then BPH, which is benign prostate hypertrophy, which is a non-cancerous enlargement of the prostate. So 1 in 6 men are diagnosed with 65 to 69 being the most common age bracket. The survival rates for localized PCA are actually very, very good. This significantly changes for advanced prostate cancer. So encouragement of regular testing when we do hit this phase of life is really, really important. And then some factors that can increase prostate cancer risk are age, family history, certain races, genetics, dietary interventions, and then lifestyle choices. So some symptoms. So localized PCA is usually asymptomatic. So again, reinforcing the idea of regular testing when we do hit that phase of life. But advanced prostate cancer can include symptoms such as sudden need to urine, difficulty or discomfort when urinating, blood in the urine or semen, unexpected weight loss, bone pain or night pain. So prostate cancer uses kind of 3 tests to help with its diagnosis. So we've got PSA, a digital rectal exam, and a prostate biopsy. So PSA is the enzyme that is found in the blood that is produced by the prostate. And when prostate cells become cancerous, PSA increases within the blood and is taken through a blood test. A digital rectal exam allows for palpation of the prostate. So we can so they feel for abnormalities, hardness, bumps or lumps. It's important to note that a normal DRE does not rule out prostate cancer, specifically in the early stages. And then you go through a prostate biopsy where they take tissues off the prostate gland, and this can help evaluate the stage of cancer once cells are looked under a microscope. So the Gleason Score and the ISUP, so both of these measures are used to identify the aggressiveness of cancer. So the Gleason Score is the picture at the top. So imagine looking at the prostate cells under a microscope where you've got an organized structure, which is number 1, versus a highly unorganized structure, which is level 5. So what they do with the Gleason Score is they take the first most common tissue type seen under a microscope and they add it to the second most common tissue type seen, and this then evaluates the aggressiveness. And the ISUP is used as a grading score. So this can help kind of clarify the aggressiveness within prostate cancer. So an ISUP grade score of 1 means that the Gleason score and the overall aggressiveness of prostate cancer is quite low. Obviously, compared to that to number 5, which means the Gleason score is quite high, which can signify quite aggressive nature of cancer. So aggression of PCA can be summarised in 2 categories. So the grade, so how fast the cancer might grow. So imagine what that Gleason score image that I showed last kind of looks like under a microscope. And then you've got the stage, so how far the cancer has spread. So common terms that can be used throughout that process are localised, so cancer is not spread between the prostate, so that'll be stage 2A. Locally advanced, cancer has extended beyond the prostate but still confined within the prostate region, and that will be stage 2B. Advanced, cancer has spread to organs next to the prostate, which will be stage 3. And then you've got metastatic, which cancer has spread to different parts of the body, so that'll be stage 4. So it's important to know that if you do work with prostate cancer patients, this can be some of the lingo that is tossed around. So I think it's important that if you do start working with these patients, that you are versed in what these terms mean. So the Tnm system, so this is a tumour node metastasis system. So it's looking at the involvement of the tumour. So what's the depth and stage of that particular tumour? The end stage is looking at the involvement of the lymph nodes. Obviously, when cancer spreads and it gets into the lymph nodes, it can spread quite quickly to other parts of the body. And then the metastasis stage is looking at whether the cancer has spread or whether the cancer is still confined to that specific part. So, for example, the prostate. So the Gleason score, the Tnm, the PSA help determine the overall nature of someone's prostate cancer. So these are kind of the things that we'll go through when a cancer oncologist is working with someone with prostate cancer. And these terms, lingo, can be given to you as part of that report card when they see you for the first time. So some treatments that prostate cancer patients can go through. So the first 2, watchful waiting and active surveillance, are generally for low-grade prostate cancer patients. So watchful waiting is there's really no treatment, but they're given regular testing to 2. Active surveillance is when there is prostate cancer present, but the aggressiveness and nature of it is quite low, but their kind of regular and structured testing protocol is a little bit more intense. You've got surgery where they remove the prostate with the surrounding tissues. You've got things like radiotherapy and brachytherapy, where radiotherapy is where they pinpoint, they shoot radio beams into the specific site of that cancer, or they can plant a radioactive implement next to the site of the tumour to help kind of break it down. Hormone therapy. So most commonly is androgen deprivation therapy. So androgen, ADT and chemical castration are both used to prevent testosterone from being produced. So prostate cancer has been shown to grow with an environment that is quite high in testosterone. So reducing the overall testosterone levels within someone can actually slow the growth of prostate cancer. But then this obviously has certain side effects that the patient goes through. And then you've got kind of basic chemotherapy and immunotherapy options as well. So some treatment side effects. So urinary incontinence is one. So prostate cancer patients may present to you utilising a absorbent pad. Loss of libido or arousal, so they may attend sessions with negativity and low self-esteem. They can come to you with cancer-related fatigue. So this is where optimising exercise sessions when the patient is most alert, I think is really important for making your intervention as effective as possible. Castration causes an increase in fat mass, weight, central adiposity, and reduction in lean mass. So we know that exercise can help have a more positive outcome in these areas as well. And then we've got kind of, because of the treatment that they go through, for example, chemotherapy, they can have compromised bone health, which obviously doesn't have a good impact on what their bone mineral density is like, which then leads to the risk of osteoporosis. So things that you would look for in a program is trying to reduce the risk of falls through implementation of some balance work, and obviously some gradual loading to kind of increase that bone turnover to kind of reduce the effect of osteoporosis. And then they can have things like bone pain, which are bone mets is also a common side effect. And things to keep in mind would be associated comorbidities. So, for example, because of the chemotherapy, prostate cancer patients and cancer patients in general can develop something called chemotherapy-induced cardiomyopathy, which is a heart pathology that has developed from the chemotherapy and the toxic nature of the treatment that the patient has gone through, and keeping a note of what that patient's treatment cycle is if they currently are going through treatment. So chemotherapy, roughly, depending on multiple factors, is generally prescribed every 3 weeks, and during one of those weeks, that person is in hospital getting their infusion. So again, so what I made the point about cancer-related fatigue in terms of optimizing exercise sessions, and this is something that I'll touch on a little bit later, is understanding when the person is most alert, whether that's earlier in the day, earlier in the week, and then establishing what that trend looks like, particularly when they are going through treatment, and then coming up with a program that is there for if they do come to you quite fatigued and lethargic, and then obviously having your kind of higher intensity session there planned if they do come in a little bit more upbeat. So some exercise considerations. So this is the APSS tool that I use to determine whether I need to implement any kind of external clarification on things, or whether I need a GP referral to see a cardiologist, for example. So this can help determine the risk factors for exercise. So some of the questions can include a heart condition or stroke, if you get any chest pains when you exercise, faint or dizziness, any specific bone pain or joint pain that you've been told could be worse by participating in exercise. So basically kind of a really, really standard screening tool that can help rule out potential need for an external referral outside of your clinic. It can identify signs of potential comorbid conditions as well, and again determines the need for medical clearance, which is particularly important. So particularly if they've come to you just after a outpatient program, so generally this stuff is kind of taken care of. Sometimes patients can come to you without with not really going through an outpatient program, but most of them these days are pretty good. So things to consider as part of your exercise consideration screening, the grade and stage that they come to you. So obviously if they come to you with quite an aggressive level of prostate cancer, then the treatments that will dictate that will be very different. How they present to you at the time of the appointment is also important. What's their training history like? Have they had previous gym experience? Are they well versed in an exercise history? Chemo cycle and chemo brain. So chemo cycle and chemo brain. So people who go through chemotherapy will often not necessarily be as attentive. So using simple cues when you are doing an initial consultation is important. Then establishing when the client could be most responsive to identify certain times and days that you can elicit your intervention. What are their training goals? So this for me is a really big factor in helping identify what my movement assessment can look like. Having an understanding of what external factors are like, for example, sleep and stress. And this is something that I was quite poor at early on in my coaching career. So I think if you can get a really good idea of what their sleep and stress are like, and also providing some information around that, I think you can have really good benefits in combination with what your exercise intervention looks like. But also be adaptable. So prostate cancer patients won't always come to you representing the same symptoms, representing the same treatment, representing the same background of prostate cancer. So be adaptable in how you do your assessment. And the question that I like to ask is, if I take prostate cancer out of the equation, what movement irregularities or differences do I see? So when I assess a squat with this person, what do I see? When I assess a hinge, what do I see? When I assess their balance, what do I see? When I assess their gait, what do I see? So I think a really good starting point for if you're looking at developing an exercise intervention or an assessment battery for prostate cancer patients is trying to really understand what their training goals are and trying to understand the task and the external environment that that person is currently in, and how they want to and what goals they have. So exercise prescription and monitoring. So these are some things that I use. So understanding their stage and grade, so having an idea about all that kind of backlingo that I talked about previously. This will give you an idea of kind of what side effects that they're currently going through, and this can give you an idea of what their current exercise tolerance is, potentially based on what kind of treatment they've had. So understanding what a progression and regression model of movements looks like. I think I posted this on my LinkedIn the other day, but this will be coming up in my next slide. Be wary of axial loading. So obviously for the urinary incontinence, just being wary of how much axial load and intra-abdominal pressure you are giving your prostate cancer patient early on. Things such as blood pressure tracking, a wellness sheet, RPE, understanding what their DOMS is like, to help establish intensity, which can help you establish exercise trends and give you a better indication of can I start to change up some of the variables based on the information that I'm getting from this person. Bone mets and relative bone pain. So to my knowledge, contraindications of movements are still a little bit unknown. So I would be wary of doing movements. Say, for example, if this person has a thoracic met, I would be mindful of doing, say, kind of like any kind of rotational power exercises. So just being wary of, if you're wanting to expose them into some rotational patterns, obviously building them up into potentially doing that. I touched on this before, but having 2 programs for when your client is more alert and when your client is high fatigue, so that your one program might look like a really basic kind of floor routine, just basic walking and a basic kind of treadmill, bike, rower kind of intervention. And then you've obviously got your kind of more extensive program for when they do start to, or for when they do feel better or more alert. And then as you kind of go through this process, you will then start to establish the patterns of how this person presents to you based on their chemo treatments and stuff like that. I think language is really, really important. So it's something that I got stuck in when I was quite young when treating this kind of population, was instead of asking a question of what is your fatigue like, try something like how are your energy levels today. So try and change the word associations with how they perceive them. So they might not necessarily feel tired when they come in, but if you ask them what their fatigue is like, they might start to associate the word fatigue with actually starting to feel fatigue. On the right-hand side, so this is kind of my training model that I use. So Jared and Joey have previously discussed what their training model looks like, and my training model doesn't change. Within the training model, things will change for sure. The things that I still want to tick off within my training model still stay the same. There's obviously certain things within that change. So I start off with what could I give this person for a home exercise, and it might not be as extensive as what I give other people, but I could give them something like a small video to watch and just follow the video. I could give them just some basic sit to stand. So giving them some home exercises too, I think, is important, particularly just to do something daily. What does their movement prep look like? So based on the estimated session that I want this person to do, what kind of warm-up exercises can I get them to do to best facilitate the exercises that I want them to do in session? What are some of the movement patterns that I want to expose them to? What does their introductory strength phase look like? And I've kind of put an example to the right-hand side for this. If I then feel comfortable in getting them to elicit a little bit more, what does their kind of secondary strength phase look like? In terms of strength facilitation, so I talked before about specific contraindication in terms of movement. If I want to do some sort of med ball movement, which you can with these patients, don't get me wrong, I might start off with some basic kind of linear stuff. So kind of more upper body focus, not necessarily getting into high velocity rotational movements. What does their energy system development and capacity look like? So this might start with some really high rest to work intervals, and then as they start to build up their capacity, then that work to rest ratio could slowly change. So what Joey and Jared kind of talked about with their models is that your model should be adaptable. So I'm able to keep the crux of my model there, just obviously things within that will look a lot different. So I think it's important to know that if you are looking at designing a training model or training system, is that, can you work with other patients outside of your current demographic that you are working with? So this is an exercise model that I use for all of my patients and clients that I see, and I believe it works really, really well. So what are some progressions and regressions of a particular movement? So if someone can't squat, for example, what are some regressions of movement that I can do with that person to facilitate that kind of movement that I want them to do? So heaps of things that you can do outside of increasing load, increasing weights, and increasing sets and reps. So you can take them from a supine to a quadruped to a tall kneeling or half kneeling to a split stance to standing to single leg stance. You can gradually expose them to different implements, for example, a med ball to a dumbbell to a kettlebell to a water bag. You can change the tempo of the movement, so how fast you want that contraction type to be. You can change the contraction type, so what initiations you want them to do. Do I want them to pull something? Do I want them to push something? Do I want them just to hold something out in front of them? And you can expose them to various movement planes as well. So hopefully this kind of gives you the idea that your progression and regression model shouldn't just be increasing or decreasing sets and reps and load. There's multiple things that you can manipulate within an exercise to still expose them to various movement patterns. And I think this is really important just for overall movement variability as well. So how they appreciate and understand different positions and how they can tolerate loads in different positions using different implements as well. So when to stop exercise. So these are the massive kind of red flags. So disorientation, dizziness, blurred vision or fainting, the sudden onset of nausea or vomiting, unusual or sudden shortness of breath, irregular heartbeat, palpitations or chest pain, leg or calf pain, bone pain, unusual joint pain or any unexplained pain, muscle cramps or sudden onset of weakness or fatigue, hernia, especially following bowel cancer treatment, and then any kind of changes in swelling you see in the abdomen as well. So generally, as a rule of thumb, I've never really had any prostate cancer patients that have been kind of in this category where I've had to stop exercise. But I think it's important that if you do start to work in a hospital setting, that this is possibly more prominent, that you will see some of these exercises, some of the reasons as to why you need to stop exercise. Here's some of the research around kind of prostate cancer and exercise. So the physical activity and survival after prostate cancer. So this is the graph at the top. So this is showing that if you can get someone to exercise that has got prostate cancer, the more that you can get them to exercise within their capability, the less chance that they will die because of prostate cancer. So importance of daily movement and trying to be active. So the more that you can exercise someone, or the more that they can exercise and move with prostate cancer, the less chance that they will actually die of prostate cancer itself. The middle graph, really interesting paper looking at PSA doubling time. So PSA, again, was the prostate-specific antigen. And if the longer that the PSA doubled leads to a more favorable prognosis. And this has been shown to be to improve with an exercise intervention. And then the bottom graph, I think, is also really important. And although it's taken in breast cancer, I thought I'd just show you this idea that when someone goes through an exercise protocol, particularly during chemotherapy treatment, the percentage of the outlined treatment that they wanted to get actually increases. So the relative dose that they were meant to get actually goes up compared to people who don't exercise. So that means that with improvements in exercise tolerance, improvements in strength, fitness, capacity, you can actually get them to tolerate more of their outlined treatment dosage. So the proposed mechanisms, so the mechanisms around the benefits within exercise for prostate cancer is still unclear. But these are some points that I've kind of gathered through research is it can help reverse causality. So it can improve prognosis by influencing PSA doubling time. Obviously, as we exercise, we get more blood flow going, so we can send the body's own immune cells to attack the tumor growth as its own. With exercise, we get greater muscle mass, which can improve the inflammatory response. So again, helping our body's own ability to attack the cancer cells, and again, enhancing the tolerability of coping with high dosages of adjunct treatment, and is really, really important. So my experiences, so every prostate cancer patient will be different. So like all clients that you guys see, assess and treat according to what is in front of you. Don't always have because someone may come to you with prostate cancer, don't always have an envisage of how that person will present, because I think you can get a little bit stuck. Try to best understand the person and their story with prostate cancer, how prostate cancer has affected this particular individual. Symptoms will vary from day to day, so be planned ahead of session for how they come in. Again, as you start to get a more consistent understanding of this person, you'll start to understand yourself, how they present to you, how they then present to you when they're currently going through treatment, and how long that then they will be feeling flat for if they have just come off a recent treatment cycle. It's a learning experience. My programming skills within this current clientele have significantly changed from the first prostate cancer patient that I've seen to the most recent one. Monitor their exercise response, so using rate of perceived exertion, blood pressure, and DOMS to assess whether your exercise modalities and intensities are right for the person who's in front of you. Encouragement. Now, this might seem a little bit silly for me to say, but this I think is particularly important. Prue Cormie, who does a prostate cancer course, talked about some, not all, prostate cancer patients will come to you with no exercise history at all, and all of a sudden they've been diagnosed with prostate cancer. Therefore, all of a sudden they're starting to feel sick, fatigued, they're lethargic. And now all of a sudden you are telling them that exercise is now more important than ever. So I think encouraging this person to do exercise, even though they are feeling quite flat, can actually be really, really beneficial for them. And don't wrap them in cotton wool. They're there to improve the prognosis of prostate cancer. So if they can increase in exercise, or if you can get them to do a trap bar deadlift, or if you can get them to do a split squat, expose them to those movement patterns like you would building up any one of your clients. So I know I got in my first prostate cancer patient that I started to do some rehab for, I got him to do a very basic kind of floor routine, and he asked me really politely to do something a little harder, and I was a little bit nervous of kind of exposing him to different movement patterns, but he said, if there's anything that is uncomfortable, I will tell you. So just again, having that open communication stream between you and your prostate cancer patient, I think is really, really important for progressing your exercises. So some resources. It took me 28 years, a pandemic, and 2 phases of lockdown to get on the Instagram bandwagon. Exercise. SR put up this Exercise in Cancer ebook that I was lucky enough to be published in last year, that talks about all things cancer, not necessarily just prostate cancer. The Reach podcast, which is hosted by Keon Fairman, looks at all things cancer oncology, so the effective exercise that has on various cancer types. There's a really interesting TED talk that looks at how cancer cells communicate, and that if we can disrupt this process, we can actually stop the spread of cancer cells from metastasizing. Prue Cormie does a really good course on prostate cancer. So if this is an area of interest for you guys, or for any of the EP students who are here, I'd highly recommend going and doing that course. And then there's a COSA position statement on exercising cancer that outlined, I think this was published last year, that outlined that exercise is now part of the gold standard treatment for exercise, which is huge in terms of the exercise oncology space. And that's me done, I think.
Brilliant. Thank you very much, Adam. Obviously something that I have absolutely no scope in, so it's very interesting to hear about these things and the way to manage these cases as well. I'm going to throw it quickly over if anyone has any questions.
Yeah, I'll jump in. Firstly, good on you for doing something slightly different to what's been presented so far. It was super interesting. You mentioned something about when you're assessing them with their squats hinge, like movement patterns, that you look past what the prostate cancer is showing to see how they would move without it. Is that to say that the prostate cancer would adjust the way they would move, and so you're looking past those dysfunctions?
Not necessarily. I think it's more to, there's no specific like movement screen that'll tell you whether someone's prostate cancer will be worse or better than anyone else's. That kind of makes sense. So if based on, and this is why I think I made the point about assessing, understanding what they want to do, particularly the tasks that they want to achieve, and you can start to mold your movement assessment around that. Is to say that, you know, if someone wants to get up and down off a chair, then I'm going to assess how they get up and down off a chair. So the point about kind of the prostate cancer is it's more probably not the prostate cancer itself, but it'll be the treatments that'll cause side effects that'll give you probably the symptoms that they will have, if that kind of makes sense. So if they do experience kind of any poor movement patterns or anything like that, I dare say it'll probably be because of inactivity on its own, not necessarily the prostate cancer itself. Yes, the prostate cancer is why they are inactive and to why they have all these kind of treatment side effects. But I don't think there's any specific assessment like musculoskeletal screening that you will do that'll tell you that this person's prostate cancer is any worse than another person. However, obviously taking into account kind of the grade and stage that they're in. So that's why I think it's important that if you are working with these people, that you do become versed with that kind of language and that kind of background. So kind of just to kind of think, okay, well, I know I got stuck with when I first started was, like this person's got prostate cancer. What on earth do I assess? But try to understand the person in front of you. So if they want to walk more comfortably, assess their gait. If they want to feel more comfortable around the house, assess how they reach things above the head, assess how they go down and bend up things, assess how they walk up the stairs, assess how they get up and down off the chair and stuff like that. So you almost start to use what their goals are to help you guide what your movement assessment looks like. I hope that kind of answers your question, Josh.
Yeah, no, that was good. Thanks for that.
Adam, have you had any experience doing, like, have you done any impact exercises to try and improve? Because I know there's some side effects with treatment for like bone mineral density loss. Have you looked into anything around, I know there's a bit on impact exercises for improving bone mineral density. Do you know much in that space at all?
In regards to prostate cancer or in general?
In regards to prostate cancer, because I know I think maybe ADT reduces bone mineral density. Do you know much about, I guess, have you done much at all in terms of impact exercises or? Yeah,
so again, I think, again, you establish whether jumping exercises are something that your patient can currently do. And if the patient doesn't really have a desire to jump, I'm not going to put them through any kind of jumping modalities or anything like that. I think this is where research can be really good and really, really indifferent in how it kind of comes across to say that, like, plyometric exercise obviously improves bone mineral density. So therefore, prostate cancer patients who do experience poorer bone health can go through an intervention, but understand that does this person actually need to dump to improve their bone mineral density, or can I get relatively the same benefits from doing strength-based exercise? So again, understanding that plyometrics obviously come with a bit more of an element of injury risk. So understanding that kind of complex around it. But in saying that though, I think there's probably out of the 10 prostate cancer patients I've had, depending on a few variables, I think I've done some sort of jumping or plyometric exercise with them. And remember that skipping is a plyometric exercise in nature. So you can inadvertently get them to do a plyometric without actually getting them to jump, if that kind of makes sense.
Yeah.
So if they are a little bit fearful around jumping, but you still want to expose them to a different thing, you can like trick them and say, look, okay, I just want you to skip, or I just want you to do some like basic kind of like, I don't know, some miniature kind of like toe tap or something exercise where you're getting them to be a little bit more boundy in nature, I suppose. But the question that I would ask is, if you are thinking about imposing a plyometric protocol within that, make sure you've kind of ticked off the basics. So can they do like a loaded squat pattern, and can they do it comfortably? Like, have you kind of like almost gone through a checklist to say like, yes, this person I think is safe to now jump. So I'd go through that before I would start jumping any patients, but the prostate cancer patients as well.
Cool.
I'll jump in. Adam, I don't want to steer the ship too far off direction because we're talking about prostate cancer, but with the unfortunate passing of Chadwick Boseman from colon cancer, how many of the same principles what you spoke about rings true across patients that may have colon cancer as well?
It's a very good question. I haven't actually had treated anyone with colon cancer. But I think, again, like the exercise model that I showed up a couple of slides ago, I think is a really good kind of way of like kind of progressing and regressing kind of movements. And that's how you would kind of progress any movements, I think, anyway. Again, I think one thing that I'm starting to get a little bit better at, but one thing that I was quite poor at, is understanding who the person is in front of me, taking time to understand who that person is, how cancer has affected them, what their journey's been like, and the particular factors such around sleep, stress, and nutrition, I think is super important. So I don't know if that answers your question, but I would take the same approach in trying to understand that person, then building an assessment protocol, then looking at what my potential exercise intervention looks like with that. Obviously, I'm not too sure what kind of happens in terms of specific treatments within that, and whether there's different side effects that you need to account for when doing your exercise. But yeah, I'd be interested to kind of know. But from my experience working with cancer, I think if you kept the same process, trying to understand the relevant information around that, I think that can help you start to unpack various kind of cancer pathologies within that. I think if that kind of answers your question, Jared.
Yeah, sure does. Does anyone else have a question for Adam?
Oh, excuse me.
I've got one more quick one. There was a point you said you were talking about regular testing. What age do you reckon that should start at?
Oh, good question. I'm probably not the person to answer that because that's not really, I suppose, my scope. But I would say, based on the data, in terms of what the most common age bracket is, I would say probably maybe 1 or 2 stages before that. For me, seems like a logical answer. Again, like the difference between survival rates between localized and advanced cancer is actually quite high. So if you can encourage people to get regular testing, to obviously stop them from getting, stop that cancer from progressing to an advanced stage, I think is really important. So I'm not too sure when testing should start, but I would say I would have a stab in saying maybe 2 age brackets before the most common kind of age bracket that it is diagnosed in, if that kind of makes sense.
Yeah, it does.
So again, probably the biggest tip is prevention is the best cure. So you can get early testing done, and you can have regular testing done. That's the best form of prevention. And I don't know if any of you, if your parents are at that kind of stage of life and saying that a DRE test, it is quite uncomfortable. I know my old man is at that stage, and I've encouraged him to go and get done. And yes, it is uncomfortable, but I think the answer of not having cancer versus having it is well. I know definitely what I would want. So encourage regular testing of your family and friends that are of that age group.
All right. Thank you very much, Adam. Really informative presentation there. It's going to come to use definitely for people in the future as well. So anyone who watches this, feel free to get in touch with Adam. He's always up for a chat and to impart some of his knowledge.